question in the
Oh,
Q&A column, or you can
examine.
ask directly to Dr. Yam later. Okay, Dr. Yam, the time is yours.
Okay, thank you very much, Alia. So today I'm going to share two topics. The first topic sounds like as anti-angina drugs, which is your focus on angina pectoris. Second topic, if we got time, I'm going to focus on chronic heart failure. So without further ado, I think I shall go further. So without wasting the time. Okay, as usual, before we go in detail, you need to understand the basic concept of certain things. For example, for this topic, you need to understand uh, the anatomical structures of hearts because angina pectoris is contributed by this coronary artery. So if you look at the left pictures, which is the blood vessels stained by red color indicate the artery. You look at the right pictures, the blue color blood vessel indicate venous. So I think everyone know
Recording in
the basic
progress.
basic structures, basic functions, basic function between the artery and venous. So artery mainly carry the oxygenated blood, which is supplied to our organ or tissue. Then the oxygenated will be bring blood will be carried from venous and then enter your systematic circulations and for further actions. So if you look at the left figure carefully, you can note that there is two branches of artery branch out from your aorta. Okay, these are aorta. So branches out. One is go to left hand side, one is go to right hand side. So even though go to left hand side, they might also branch out and then go to your posterior part. Look at this artery, which is I highlighted here is a posterior part, means that belakang behind your heart. So same thing happened in your right hand side artery also. So the right hand side artery we call it as a coronary artery. Okay, the left hand side we call left coronary artery. So these are the main artery that supply your oxygenated blood to your heart. Without this supply, your heart will not able to function well. Okay, so the angina pectoris or heart attack normally occur in this core artery. Either in small parts or main parts. If happen in main parts, then the severe symptom will occur. If let's say appear in uh, the small parts, which is small branches, then the symptom will be less compared to the major parts. Okay. Now I think you're able to appreciate the anatomical structures of your heart. So, what is a coronary artery? Actually, coronary artery is the artery that supply blood to your heart. That one everyone know. So the problem is these coronary artery are susceptible to form a plaque. Plaque we call plaque. Meaning that this artery compared to other artery in your body, this artery is more tend to have this plaque. Meaning that they are more easy to get fatty deposits. So look at the right picture here. Supposedly your rumen is occupy the main parts of this location. Unfortunately, this artery is undergo uh, atherosclerosis, and the main major parts of the rumen is occupied by plaque. Okay, so that's why only small portions or small location allow your blood to flow. Okay, that's why when your coronary artery undergo these conditions, then you tend to have heart attack. So clear the basic concept. So what we do is before the condition getting worse, we try to do precautions to prevent the condition getting worse. So what we do is we do sufficient exercise, we control our diet, then be able to lower the risk. Okay. So another term you need to understand is atherosclerosis. Okay, what is the meaning of atherosclerosis? Atherosclerosis refer to fat degenerations of your coronary artery. Not only fat deposit, but already undergo degenerations. Uh, Meaning that compared to deposit, degeneration is far more serious. Okay, so with these conditions, then you tend to have ischemic. Okay, what is ischemic? Ischemic is meaning that the decrease of blood flow. Okay, supposedly maybe your normal coronary artery can carry 90% now because of this atherosclerosis. Then uh, the function will decrease to 10 or 50%, depend on the conditions. So, okay, an individual develop atherosclerosis and experience of cardiac ischemia, then we call it as coronary artery disease. Means that you have one time, many time of heart attack and experience of cardiac ischemia many times, then we call it as coronary artery disease, CAD. So clear? Then how about angina pectoris? Angina pectoris refer to the symptom of chest pain. So meaning that these three, you should separate them and understand them carefully. The first one is atherosclerosis, second one is ischemia, third one is coronary artery, and the last, another one is angina pectoris. What is angina pectoris? Angina pectoris basically refer to chest pain. So this chest pain normally is due to CAD, coronary artery disease, and then the chest pain is come because of insufficient of blood flow. Then your heart muscle undergo an aerobic activity, so that's why uh, you have chest pain. So complete blockage means that totally no lumen here, 100% been blocked. So these conditions normally will result myocardial infarctions. Okay, meaning that no blood supply to your muscle. We call it as myocardial infarctions, and uh, in this condition we call it as a heart attack. So heart attack and angina pectoris is also have some difference. So heart attack is more serious. Heart attack is myocardial infarctions. Angina pectoris just like chest pain. So the important of the treatments for this condition is we try to prevent the condition getting worse. You can perform the treatment or you can do the preventions. Okay, what we do is normally we use nitrate, beta blocker, and calcium channel blocker for angina patients. So I repeat again, these three uh, groups of drugs are going commonly been used to control or treat the condition. So beside that, you also need to have a good, healthy daily life. So you need to do exercise. You need to quit from smoking and also control your body weight in order to prevent the condition getting worse. Okay. So today for this topic, we are going to cover nitrate, beta blocker, calcium channel blocker as well. So the first topic we are going to cover before that we need to classify uh, the angina pectoris. Okay, angina pectoris actually is a symptom lah. We need to we need to classify them. How to classify them? Depend on the stability. So okay, those angina condition which is stable, then we classify as stable angina. Those are not stable, we classify as unstable. What is the meaning of stable? Stable means that you're able to predict. For example, uh, exertional angina only happen when insufficient coronary artery flow due to heavy activity or stress. For example, some people they had chest pain after they do exercise. So meaning that they know the condition will going to cause the chest pain. So this type of angina pathology we classify as exertional angina. Okay, clear? So the second type of stable angina we call it is a Williams angina. Okay, due to vasosplanch. Vasosplanch means that the vasocontraction happen suddenly in your coronary artery. So normally happen during nighttime after you sleep, after the patient sleep. So they will pass away just like that. Okay, these are normally classified as Williams angina because of sudden vasosplanch happen. Okay, so that's why some people they might have both exertional angina and also Williams angina as well. Okay. Once you have chest pain, as episode of chest pain, then you need to be careful. So you can do treatments, you can do preventions. Okay, later we're going to discuss, don't worry. So unstable angina means that uh, more serious conditions happen, which is an advanced stage of coronary artery. So it's totally uh, infarctions occur, then the patient might have myocardial infarctions. Okay, then we call it unstable. So for unstable, you need to do surgery or extra treatment. Not only depend you cannot depend on drugs. You can do further. You need to do further treatments. So for this unstable, normally what they do is they treat with anti-angina drugs like what we discussed just now. Beta blocker, calcium channel blocker, nitrate. They also treat with anticoagulations and antiplatelet drugs as well to prevent things happen. So if possible, the patient is need to do angioplastic and uh, surgery or coronary artery bypass surgery, depend on the conditions. So clear, isn't it? It has two types of, and then the first type can divide it into two, another two subtype, and then unstable one. Normally, the way we treat is different. So normally they prescribe the drugs while waiting the turn for do surgery because surgery is long queue, isn't it? So you need to wait the turn. So while waiting the turn, you need to prescribe these three types of approach to the patient. So the first drug, just now I promised we are going to study three drugs, isn't it? The first drug is nitrate. So the functions of nitrate is dilations. So we call it vasodilator. Okay. But you need to bear in mind when a blood vessel, especially coronary artery, undergo atherosclerosis, if you use nitrate, there's no more uh, dilations occur. Because why? Atherosclerosis is the degeneration process, isn't it? So once degeneration happens, the ability of dilation is no cannot perform very well. So even though you use nitrate, at the end there's no significant dilations happen. But why we still need to use nitrate? Because nitrate is a vasodilator for other parts of your blood vessel as well, not only coronary artery. Once you use nitrate, you will produce vasodilations in your systematic vein and artery as well. By doing so, your venous return and will be reduced, and then your cardiac work will be reduced, meaning that your heart will be in more relaxed conditions, and then oxygen consumption will be reduced as well. So that's why we'll reduce your pain conditions. Okay, understand? So here for this slide, you need to understand nitrate will not cause significant effect on your the coronary artery when the coronary artery have been undergo atherosclerosis. Only thing is nitrate help in this type of patient by lowering the venous return and also cardiac output as well. Okay. So we go further. So the mechanism of actions of nitrate is quite clear. Since we call it nitrate, that's why uh, from the name, we know that this nitrate related to nitric oxide. Actually, nitrate is the ion that uh, required from your body to produce nitric oxide. What is a nitric oxide? Nitric oxide is a potent vasodilator, meaning that can cause vasodilation. Look at the right hand side. This is the vascular tone of your blood vessel, especially arteria. What is vascular tone? Vascular tone is the mechanism of contraction and relaxation. They will call it as vascular tone. So there's two part, main part in your blood vessel. One is endothelium, one is a smooth muscle. The upper part is endothelium, the lower part is smooth muscle. Okay, what will happen? Okay, basically nitric oxide will be produced in your endothelium. Yeah, look at the highlight parts here, nitric oxide, with the help of endothelium nitric oxide synthesis. Okay, once the nitric oxide been produced, nitrite will migrate directly into your smooth muscle. So once into your muscle, that nitric oxide will initiate the soluble guanyl cyclic. This soluble guanyl cyclic will activate. Once activated, it will convert your GTP to cyclic GMP. So your cyclic GMP will cause productions of PKG or activation of PKG, and this PKG will further and activate. Look at the red color, white, black color line here. We activate your MLP. These are the vasocontraction or vasodilation process. Okay, with the help of calcium, of course, you need to have calcium. So if you got time, you go back and appreciate this mechanism of action. This one is drawn by me. Okay, after I go through hundreds of articles and then I summarize the mechanism of actions. Okay, we call it as a vascular tone here. Okay, not only nitric oxide, other receptor might also involve in vasodilation, or we call it vascular tone. Okay, such as potassium here, calcium here. Calcium got three types. One of them, the most famous one is VOCC, which is most of our drugs is add on this VOCC. So so we back to nitric oxide. See, we know that nitric oxide is a vasodilator. So which part we're going to dilate when you prescribe when the patient is taking nitric oxide? Venous. Venous is a greater is dilate more than artery. So we call venous. Okay. These drugs dilate more venous than artery at low dose. When you increase until maximum dose, another story. Everyone will become saturated. So the effect will be similar. When low dose, they will dilate venous more than artery. Okay. That's why they highlight low dose. Okay. In high dose, everyone become maximum dilation, so you cannot compare anymore. So Once you dilate, they will decrease the venous return because the dilations and the blood vessel will reserve as reservoir for your blood. These venous will reserve as a reservoir. Once dilate, they will capture more or they will keep more blood in order to bring the blood back to your heart. Okay, so that's why we call it as a they will call decrease in preload. So we have two types of loading. One is preload, one is afterload. Afterload means that the conditions after your heart, meaning that after pumping out. Then preload is before enter your heart, we call preload lah. So and will decrease the blood pressure after load, meaning that this route able to decrease after load and decrease preload. Why? Because your heart, if let's say you supply less blood to your heart, what will happen? Your heart will not going to pump more blood out because your resource is so limited. So they based on your resource, they pump the amount according to your resource. So that's why they will pump out less. So your afterload will become less. Okay, clear? So by doing so, your heart work will be reduced. So your heart will become more relaxed compared to before the treatment. So you then the pain will be released, relief lah. Okay, clear? This is the mechanism of actions. Okay. So how many types of nitrate normally we use or available in market? There are three types: nitroglycerin, isosobite nitrate, isosobite mononitrate. So what is the difference between them? You look at the table here. The main difference between them is the onset time and durations. Onset time is you need to they need to take how long to onset to show the activity. Duration means that the activity will remain on how long. So only the difference is the onset time and duration. Basically, the mechanism of actions are more or less same. And also another difference is where type of administrations. Okay, whether it's able to use in IV or able to use in sublingual. Okay, so the most common uh, administration is sublingual. Sublingual means that you put under your tongue. So normally this type of drugs we call it as a sublingual nitroglycerin. So normally we take 1 to 3 minutes to show the activity. 1 to 3 minutes. So the activity will become peak at 5 minutes. And then the duration is 30 minutes, means that the duration is quite short. So sufficient for you to send the patient or the patients to seek for medical treatments. Okay. So sublingual administration will the beauty of sublingual administration will avoid the first pass metabolism by your liver. So what is the first pass metabolism? First part is metabolism is the metabolism happen when the drugs absorb from your intestine before enter your liver. During the process of absorption, the metabolism happen. We call it as a first pass metabolism. Okay. So when your drugs undergo this first pass metabolism, then you will lose the activity. If they're going to metabolize to inactive form. So another type is uh, nitroglycerin ointment. So you can apply topically on your chest. So they take 30 minutes and the duration is to onset, the duration is 4 to 8 hours, meaning that these types of formulation will stay longer in your body. Okay. So there's another type of formulation, we call it nitroglycerin extended release capsule. So they purposely formulate into a special capsule which is can control release. So normally we're up to the duration up to 12 hours. Okay. This one can use for prophylaxis purpose, meaning that you take one, so can help you for 12 hours, 12 hours. And then another one is triderma nitroglycine. Uh, you can actually it's formulated in the patch, so you can patch in certain locations. So more long lasting, 24 hours the duration. Okay. So actually the formulations is depend on your needs. If emergency, normally we are not going to use the uh, this types of because the onset is quite low, isn't it? Quite take some time. So normally if emergency we use sublingual. Okay. So for drug interactions, since they involve nitric oxide pathway, those drugs that involve nitric oxide pathway might also will interact with this nitrate. I give you a few examples. Viagra, Cialis, Levitra. These three are the drugs that we use to treat erectile dysfunctions. Okay, because the mechanism of pathway are quite similar. Only thing is the target organ is different. This Cialis with this Cialis, Viagra and Levitra are more focused on your penis, and the nitrate is focused on your coronary artery. Okay, but basically the mechanism of action is similar. They produce nitric oxide, and then nitric oxide will cause vasodilatation. If you use them together, then you might have some problem because they share the same mechanism. You might cause excessive vasodilatation, hypotension, reflex tachycardia, and potential myocardial infarction as well. So bear in mind when you want to prescribe these drugs, you have to understand whether the patient is taking another type of drug or not, especially share the same mechanism of actions. So the second drugs we are going to discuss for this angina condition is beta blocker. So as we know, there's two types of beta receptor. One is called beta 1 receptor. Second one is called beta 2 receptor. Beta 1 mainly are found in your heart. Beta 2 are mostly dominate in your blood vessel. If you block beta 1 receptor, then you are might able to block the sympathetic stimulations, meaning that you're able to increase the heart rate, you're able to reduce the contractions force of your cardiac muscle. Okay, so if you able to reduce the heart rate, you're able to reduce the force contraction, meaning that you decrease the oxygen consumption. So your heart will become more relaxed, like what happened in nitrate. Okay, so your heart workload will be reduced, so will prevent the ischemic conditions. So beta blocker is good for long term management for angina pectoris. Okay, long term because the side effect and everything is well known, so it's good for long term. So what type of beta blocker normally prescribed for chronic patients? Here we have propranolol, okay, which is the most commonly prescribed drug. So sometimes if necessary or you want in certain condition you can combine nitrate and beta blocker as well. Okay, because the conditions, the mechanism of action is slightly different, isn't it? So you even though it's called vasodilatations, but different approach. Okay, so you combine them together. You can. The adverse effect is beta blocker. It may cause drowsiness, tiredness, gastro disturbance, and also such as gastro disturbance means like gangguan gastric, gangguan gastric, because they are trying disturbance. such as nausea, diarrhea. Okay, sometimes if you give them overdose, you may cause a bradycardia, hypotension, uh, heart failure as well. If extremely high dose you give to the patient. So try to avoid give maximum dose. Okay, I repeat again, maximum dose. Try to avoid. If you want to do maximum dose, let's say you use certain dose, there's no effect. Then you thought that you increase until maximum dose is good for the patient. Actually, it's no good for the patient. You can consider once to come to that condition, you need to consider whether you need to combine one or two drugs together. So in order to take one drug and give prescribe until maximum concentration. So if you use a beta blocker, you have to bear in mind whether it's selective or non-selective beta blocker. If you tend to prescribe non-selective beta blocker, so bear in mind the patient is not COPD or asthma patient. If COPD and asthma patient, they might cause vasoconstrictions, bronchial constriction, not vaso, sorry, bronchial constriction. So beta receptor 2 that found in your respiratory tract might act as vasodilation. Once you block the beta 2 receptor in your respiratory tract, meaning that you is causing bronchus contractions, meaning that you contract the bronchus. So you try to avoid. Huh? Okay. So just now I do mention there are two types of beta blocker, isn't it? One we call it as non-selective, one we call it as selective. So what is the difference between them? Non-selective one is they focus on beta 1 and beta 2 as well. Then the selective one only focus on beta 1. Even though they say it's beta 1, but actually they have some activity of beta 2 as well. But only thing is beta 1 will dominate the conditions. Right. Okay, sorry, I forgot to unmute. So basically there are two types, isn't it? Non-selective and selective. I give you an example for non-selective, such as propanolol, nadolol, selective one, atenolol, and metoprolol, selective one. So the third drugs that used for angina is calcium channel blocker. So the main mechanism is try to block the influx of calcium ion into your smooth muscle, especially your vascular smooth muscle. Without this calcium, though your heart, you're not going to pump. So meaning that they will affected your depolarization process. Okay. So during the depolarization, you need to have calcium, infusions of calcium. So once you uh, prevent the infection, so you are meaning that you are interrupt the depolarization, okay, process of your smooth muscle. So without this depolarization, so your smooth muscle we are not going to contract. We are going to undergo vasodilatation. So by that's why we call it as a sometimes we consider back calcium channel as a vasodilator as well because the end uh, at the end this calcium channel we're going to cause vasodilatation, isn't it? And then by doing so your blood pressure we're going to reduce. So basically this calcium channel we're going to reduce our cardiac work afterload and also will reduce your oxygen consumption. So calcium channel is basically suitable for Williams angina, one of the stable angina. Okay, uh, and also because this why variance? Because variance sometimes we know that variance is caused by vasospasm, isn't it? So once you have this vasodilatation activity, then you're able to overcome the vasospasm, especially during nighttime or sleep. So you can use this drug for the prevention purpose because these drugs mainly can cause a vasodilation in your artery. Okay, so this drug also may interference your infections in of calcium in your SA and AV nodes because infections calcium in SA nodes and AV node uh, we are going to contribute to the action potential of SA nodes and AV nodes. We have two types of action potential. Action potential that happen in your small muscle and action potential happen in your pacemaker. This SA and AV nodes are considered as pacemaker, so the mechanism is slightly different. The pattern of action potential is so slightly different. Okay, so calcium channel might affect the not only in your action potential in your blood vessel, but also in your pacemaker cell. Okay, quite different. So the most commonly used are verapamil, diltiazem. They have been clinical proof that able to reduce your cardiac output and then good for angina patients. So calcium channel basically can divide it into two types. One is non-hydropyridine, one is hydropyridine. Okay. Non-hydropyridine basically able to use for angina pectoris, especially verapamil and diatism. Okay. And then hydropyridine some of them able to use for angina pectoris. Most of them are used for hypertension. Okay, I give you for example, the most commonly prescribed is amlodipine, isn't it? They are basically can use for angina pectoris and hypertension as well. Okay, some of them cannot. It's not suitable for angina pectoris, such as philodipine. It's not suitable for angina pectoris. Only suitable for hypertension. So So since we know that some of them are able to affect your heart uh, action potential, some are not able. So that's why they divided into calcium channel. They divided into two types. So one with direct cardiac effect, one is without cardiac effect. So with cardiac effects is such as verapamil and diatism because these two types of drugs it belongs to non-hydropyridine types of calcium channel. Okay, what they can do is they can decrease your heart rate. They also can decrease your AB conductions because your heart pumping is normally is fire by impulse, isn't it? So these types of drugs able to reduce your AB conductions. Okay. So by doing so, your heart rate automatically will become uh, slow. Okay. Same thing happen in diazepam as well. So basically, they able to uh, reduce your AV conductions. So you won't be supplying this type of drug able to use to treat or to control the arrhythmia condition. Arrhythmia is in regulations in contractions of your heart. We call arrhythmia. Is able to use to treat arrhythmia conditions because they able to alter your AV conductions. So and another type of calcium channel, we call it as calcium channel without direct uh, if affected your heart. Okay, so there are few types of. One is nifedipine. Okay, and another is amlodipine. The others members. Okay, so nifedipines basically have very little effect on the heart. Only thing is this drug can able to cause vasodilation. So once you cause vasodilation, especially in the artery, what will happen? They will lower your blood pressure. First thing, okay. They also will reduce your afterload. Okay, then your heart will be more relaxed. Okay, because your heart load will be reduced. Okay. Okay, another type is just now I mentioned is member of such as the members such as amlodipine, phenoldiphine, and istadipine. So what they do is this type of drugs do not directly affect your heart. These drugs only able to cause vasodilation. Same thing happen like nifedipine. So the most common effect is uh, for calcium channel is flushing. Your facial flushing means that your face become full of blood. We call flushing, red color. Headache, dizziness, hypotension, gastrointestinal disturbance. Okay, so sometimes for calcium channel blocker, which is direct affected your heart effect one, such as verapamil and diazepam. If you use these two types of drug overdose, you might cause bradycardia because they will affect your AB conduction, isn't it? So might cause bradycardia. Okay, if this is the main concern, bradycardia. So normally, uh, you are not suggested using verapamil combined with diazepam because they share the same mechanism of action. You may worsen the condition, and sometimes you might also increase the uh, side effect as well. So try to avoid using the same mechanism of action drugs together. So this slide trying to show you the concept how to treat how to select the drugs for angina. First thing you need to differentiate the patient whether belongs to stable or unstable. Okay, if the patient are in stable angina, then you need to classify them whether is exertion of or variance angina. Even though they are belongs to same category, but the approach are slightly different. If let's say they are belongs to associations of fixed stable, you know that when you do exercise, you're going to have angina. It's easy. You can use nitrate beta blocker calcium channel to control the condition. Okay? So if let's say you also need to consider the same patient, the same group of patient which belong to this stable angina, whether they have other conditions as well or not. If let's say they have hypertension, so even though not all hypertension patient are going to have angina, not angina, all angina patient have hypertension. Okay, and if let's say they have both associations, exertional angina and also hypertension, you can consider calcium channel or beta blocker because you can use both to the both drugs able to control the condition and also be able to reduce the hypertension as well. If the patients have sympathetic activity as increase of sympathetic activity, then you need to select beta blocker. Okay, instead of calcium channel, you need to select beta blocker because beta blocker able to overcome these conditions. So if let's say the patient belongs to variance angina, then you can select calcium channel and also nitrate as well. You combine them together. Okay. So in order to prevent the tolerance conditions, you can divide them. Morning you take one type of drugs, after at night you take another types of drugs. So you try to prevent tolerance conditions. Okay. So normally is nitrate, because once you frequently using nitrate will develop tolerance. So you need to have a drug-free interval, especially at night. So at night you take calcium channel blocker, morning you take nitrate. So to avoid the unwanted conditions. So unstable angina. So you need to have nitrate, antiplatelet, anticoagulations, or vasodilator combinations treatment in order to prevent the condition getting worse. Once the condition stable, then you can consider for further treatment such as bypass and also uh, angioplastic surgery. Okay, angioplastic surgery is such as you implant stent or you just using the balloon to dilate the cornea artery. Depend on the condition. Some condition you need to implant that, some no need. So here, uh, recently they have developed the soluble stent, meaning that they implant the stent. The stent is not made by uh, steel, stainless steel, not or platinum. The stent is made by chemical. So once you implant the stent, after few months, the stent will going to dissolve. They call it as uh, soluble stent. So also you can also consider soluble stent as well. The beauty of soluble stent means that you once you put the stent, few months later the stent dissolve, then your condition is different compared to you put the permanent stand. Permanent stand it means that the stand will be forever there. So once the stand is there, might cause a certain unwanted side effect. Okay. So thank you very much. So we go to another topic. Since we got still got 1 hour, so we go to another topic. Okay. So for second topic, we are going to discuss on heart failure. How to treat heart failure. So the definitions of heart failure is the heart are not able to pump adequate amount of blood to your organ. So the definition is quite straightforward, isn't it? Okay, your heart cannot pump sufficiently, and then cannot pump adequate blood to your organ. Then we consider as chronic heart failure. Normally, heart failure is chronic type lah. Okay, chronic time means that take very long time to develop. So when a person have a chronic heart failure, meaning that heart cannot pump the blood, sufficient blood to the organ, but the patient still can able to survive. Don't worry. Why? Because your body can compensate the condition. Your body try to overcome the conditions. The, this mechanism we call it as compensatory mechanism. Okay, compensatory mechanism. So what your body going to do is your body will undergo hypertrophy, especially your cardiac muscle. Okay, then because why hypertrophy will occur because your heart will going to work harder to pump more because you are not sufficient to you cannot pump sufficient blood to your organ, so your heart will do will how to say will 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 become how to say will 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 pump more, will work more, so the muscle become hypertrophic. So like you go to gym, then you practice, then your muscle become uh, bigger, then this condition we are considered as hypertrophy. Same thing happen in your heart also. Your heart will uh, will pump more, will work more, and then will become bigger size. Then the cell become bigger size. Then we call it a hypertrophy. Hyperplasia and hypertrophy is different. Hypertrophy means that the size become bigger, but the numbers of cells remain the same. Hyperplasia is the number of cells become more. So hypertrophy means that the number of cells still remains same, but only thing the size is different. Increase. Okay. So once hypertrophic increase, and then your heart become bigger size, isn't it? Then once the heart bigger size, some of us we thought that it's good for you, isn't it? But actually it's not good because the capacity of your heart becomes smaller because the capacity is occupied by your muscle of your heart, so becomes smaller the capacity. Okay, meaning that your heart chamber will become smaller because will be occupied by your smooth muscle. So if you didn't control the condition, then you tend to have heart failure, and then you have certain death. You might have certain death. So this condition we call structures remodeling. Your heart try to remodeling your structures. So the process, this compensatory mechanism involve sympathetic nervous system and kidney activations. So still remember, we do discuss the first topic hypertension. I do highlighted sympathetic and kidney um, contribute more for your cardiovascular system compared to other organs. So what is the compensation? Okay, look at this the left hand side. Okay, when your cardiac output reduce because coronary artery failure, your kidney. Okay, we look at one by one first. You look at kidney first. Your kidney going to produce. Yeah, of course, your cardiac output is reduced. Your kidney will going to receive less blood, isn't it? Supply. Okay, less blood supply. Then this condition will activate your kidney to produce renin. As we know, renin is the important material to activate your RAS mechanism, isn't it? So once your renin been produced, so automatically your body going to produce more angiotensin 2 at the end. Okay, this angiotensin 2 will going to cause vasoconstrictions. Your blood pressure will increase. Okay, and also will cause another organ to produce two important elements. One element we call is ADH, antidiuretic hormone, and one we call aldosterone. Okay, antidiuretic hormone actually is produced from your adrenal cortex. This aldosterone basically is produced from your hypothalamus. Okay, not produced from produced from your hypothalamus. Yes, from no, produced not. Aldosterone is not produced from the hypothalamus. Aldosterone produced from a pituitary gland. So, meaning that once this condition happens, for example, increase of antidiuretic, then your kidney will going to absorb more salt and more water, causing sodium retention and water retention. Because they thought that cardiac output decrease due to you do not have sufficient amount of blood or water. Okay, that's why they produce, they absorb more water to increase the volume of your blood. Okay, bloodstream. So that's why they produce antidiuretic drugs. So this antidiuretic going to increase the absorption of water and sodium as well. Okay, okay, clear. So how about aldosterone? Uh, how about aldosterone? So same thing happen. Aldosterone may also uh, uh, cause water retention. Okay, water retention to increase more water. So once you increase more water, your blood pressure will going to increase. These are considered as the first type of compensation response caused by kidney. So what happened for your blood vessel? Okay, your uh, brain will automatically produce more vasoconstrictor. Okay, the condition we call it as stimulations of sympathetic discharge. So once sympathetic stimulations have been activated, they will produce norepinephrine. Epinephrine. These are element will going to cause uh, vasocontraction and increase your heart rate and your cardiac contraction force as well. So meaning that your cardiac output will going to become will increase. Sometimes back to normal, sometimes not necessary. Yeah. Okay. So combinations of these two scenario we call it as compensatory response. Okay. So at the end, what they trying to do is they try to increase your cardiac output because during the heart failure, your cardiac output is decreased, isn't it? So with the compensatory response, your cardiac output will going to increase. Okay. This condition we call remodeling or compensatory response. It's automatically done by your body. So for short term, okay, you can overcome the conditions. For long term, might harm yourself. So until the end, your heart cannot pump anymore, then you might have certain death. So how to treat chronic heart failure? Normally they use certain they have certain approach. One is you increase the contraction of heart. So normally they use cardiac glycoside to stimulate the myocardial contraction. So sometimes they also use vasodilator to cause vasodilation. Okay, to reduce the workload of your heart. Okay, okay. Uh, either the workload is focused on venous or artery, it doesn't matter. The the vasodilator you may select either is uh, venous dilator or arterial dilator, doesn't matter. Both also will contribute to your treatment. So sometimes they also select diuretic because they don't want to they want to excrete out extra fluid from your body. So they use diuretic, meaning that they don't want more water retention, so they excrete out. So far, the concept to treat CHF chronic heart failure is you need to select cardiac glycoside, you need to select vasodilator, you need to select diuretic, three types of drugs. So for cardiac glycoside, so far, only one type of cardiac glycoside is still available in our market. We call it as a digoxin. Uh, Digoxin still can use. Normally, this digoxin is considered as second line drugs. No more considered as preliminary drugs. First line defense, first line treatment. Sorry, first line treatment. Considered as second line treatment. So, uh, for diuretic uh, drugs, you can select thiazide diuretic, organic acid, potassium sparing diuretic, which is we have discussed in last topic, isn't it? What's the difference between them? Some of them can cause loss of potassium, some of them will reserve the potassium, loss of potassium. Reserve the potassium, meaning that without causing loss of potassium, depend on the condition. And another thing is among these four types of diuretic, which one is more potent? Organic acid, or we call it loop diuretic, is more potent. Okay, more potent. But basically, they share the same concept. Only thing is different drugs might have different on different locations of your nephron and your tubular. So might add on different locations. So thiazide light diuretic normally is used for moderate, uh, or we call mild to moderate coronary heart failure patient with normal renal function. With normal renal highlight here. Thiazide is for normal renal function. Okay. Okay. And then another thing, I repeat again, when you use thiazide for long term of failure, you might cause loss of potassium. So this one you need to bear in mind. This condition we call it as hypokalemia. So okay, settle. So loop diuretic is suitable for impaired renal functions with chronic heart failure conditions. Okay, okay, is suitable for uh, impaired renal function means that your renal is not normally functions, what we call impaired renal function, and severe heart failure patients. Okay, suitable. Because why? Because this loop diuretic is the most potent diuretic. Okay, the acting site is loops of Henry, loop of Henry. Compared to thiazide, the acting site is a distant tubule. So that's why just now I highlight they have the same mechanism of action. Only thing is different location. Different location. Okay. So okay, I highlight the important now. Thiazide is for normal renal functions patient with mild to moderate heart failure. So loops directly is suitable for severe patients with impaired renal function. So aldosterone antagonist, okay, sometimes we also call it as a potassium sparing diuretic. Okay, add on collecting the drugs, collecting drugs are different. Just now I mentioned is a different part for different locations. So add on collecting drugs, and the beauty of this drug is able to reserve your sodium, potassium, able to reserve your potassium. So normally it's suitable for they didn't mention which type of patient, but generally it's suitable for moderate, moderate, mild to moderate, depend on the conditions. So adverse effect of diuretic is may cause hypokalemia, hypotension, hypokalemia, hyperuricemia. Last week I do discuss it and why because competitions. Okay, hyperuricemia means that uric acid will increase. Hyperglycemia also because of intolerance or insensitivity of insulin. Okay, receptor. Okay, again, sir, if you require potassium sparing, then you use potassium sparing or aldosterone type of diuretic drugs. So the second cheap drug that normally will be used is vasodilator. So uh, okay, vasodilator you can select those to add on afterload or those to add on preload, doesn't matter. If you want to consider, you want to select those drugs have balance on afterload and if balance effect on afterload and preload, then you can select ACI and ARB. These two types of drug is because they cause balancing. They balance afterload and they balance preload, meaning that they have both effect on afterload and preload. So that's why the two drugs is quite good. And then another thing is ACI and ARB is less toxic compared to others. Okay, it's good and then less risk of toxic if you especially you combine with digoxin. Okay, okay. Everything I just highlight important part. So you can use hydrating also because hydrating is for mostly add on your arterial is venous is considered as arterial vein vasodilator. Okay. So only thing is the adverse effect is for hydrating is may cause excessive decrease of blood pressure and cause nausea, hypotension, headache, and reflux tachycardia as well. So if okay, what else? Okay, we go to nitrate. Nitrate is mostly just now I do discuss, isn't it? Nitrate is mostly focused on your venous. So that's why they sometimes they call it a venodilator, even though they have some effect on other artery as well. But we consider generally we consider as venous director. So the side effect of nitrate either is nitroglycerin or isosobate nitrate or mononitrate is they might have a headache, dizziness. They might cause a headache, dizziness, vasomotor flushing, postural hypotension, reflex tachycardia as well. So for balance vasodilator, just now I do mention, isn't it two types, isn't it? ACI and ARB. Okay. So it depend on the conditions, what you want, Okay. So even though just now we mentioned that ABI, ACI is a balance, sometimes AC, uh, okay, we back to the second point here. this drug inhibit the actions of angiotensin 2. We know angiotensin 2 either is prevent the production of angiotensin 2 or prevent the activity of angiotensin 2. Then will cause vasoconstrictions and release of aldosterone. And then release of aldosterone, release of VH means that you're going to reduce the release of aldosterone. Still remember, we do discuss decrease this one. Angiotensin 2, we're going to increase the aldosterone and ADH, isn't it? So when you have AC and ABI, your you're going to reduce your angiotensin 2, isn't it? So without this angiotensin 2, so your aldosterone will not going to stimulate, isn't it? The excretion of aldosterone and excretion of ADM are not going to stimulate because the amount of angiotensin we're going to be reduced. So will cause what? Will cause another unwanted effect. Oh. Okay. So last week I do discuss the difference between ACI and ARB is ACI because decrease in activation of bradykinin, meaning that bradykinin will become relatively higher than without the treatment of ACI. So this bradykinin we're going to contribute for what? We're going to contribute for certain activity like hyperallergy, okay, allergic conditions, and also autoimmune sometimes may develop autoimmune. Okay, dry cough as well. So angiotensin receptor blocker do not have these conditions because this angiotensin receptor blocker we call ARB will only block the angiotensin 1 receptor, prevent angiotensin 2 to contact with angiotensin 1 receptor. Okay, clear? So the adverse effect is especially ACI will cause dry cough and allergy reactions. Okay, so then when we come to another type of drugs, we call it as a beta blocker, calcium channel. We do discuss uh, vasodilator. We do discuss. Then we come to beta blocker, or we call adrenergic receptor blocker. Either it's beta or alpha, doesn't matter. Now, today we'll focus on beta one. Then we know that when you block beta one, the effect will be directly on your heart. Your heart contraction will be reduce. Your heart uh, contraction will reduce. Your heart force will be reduced. Your workload will be reduced as well. So your heart is more more in relaxed conditions, so you can overcome the conditions. So another thing you need to remember here is beta 1 receptor might also found in your kidney, especially your juxtaglomerular cell, okay, which is produce your renin. Once you inhibit this beta 1 receptor, meaning that you are inhibiting the release of renin from your juxtaglomerular cell. Okay, clear? So you have to bear in mind. So you use beta 1 receptor, you might have extra activity which is reduce the release of renin. Okay. Reduce the reading of renin means that you are inhibit the RAA receptor activity, isn't it? You might not cause harm, uh, uh, might cause harm, extra harm to your body, especially your heart. We saw angiotensin 2 we're going to cause vasoconstriction, isn't it? Then once vasoconstriction will increase your afterload. Once you increase your afterload, what will happen? Your heart will need to work more. So instead of relax, then your heart will be work more. Then your heart will undergo more hypertrophic conditions. Okay. So cardiac glycoside. Okay. Cardiac glycoside is quite important for heart failure patients. They will cause vasocontraction. No, sorry, not vasoconstriction. Your cardiac contraction will increase your cardiac contractibility. Means your heart will work more. Okay, will pump more, will contract more. So okay, this is a mechanism of digoxin. Okay, digoxin basically will block your N and natrium and kalium adenosine triphosphate. Okay, activity is an enzyme will block here. Then once this enzyme has been blocked, what will happen? Your pump, your sodium potassium pump will be inhibited. Then will cause accumulations of natrium in your intracellular. This intracellular refer to your heart muscle. Okay, heart muscle. So once accumulation of natrium, so automatically this condition will cause uh, reduce of uh, ion exchange activity, meaning that suppose this ion exchange activity is you are going to bring in natrium and then bring out calcium. So since your natrium is quite plenty in your intracellular, meaning that this channel are not stimulated, will be inhibited, no more natrium will be bring in. So once no more natrium will bring in, no more calcium will bring out. So in another word means that you will going to increase the concentrations of calcium indirectly because of you are inhibiting uh, the natrium calcium exchanges. So no calcium will going to pump out because of too plenty of natrium. Okay, you no more need to bring in the natrium. So no more bringing the natrium, you are not going to pump out the calcium. So what will happen? Calcium will accumulate. Once calcium accumulate, you will cause contractions. Your heart will be contract more. Okay. So by doing so, you can reserve more activity or more functions of your heart. Okay. This is the beauty of uh, digoxin. Okay. So adverse effect is cardiac arrhythmia and also ectopic beat. Yeah. Okay. Cardiac arrhythmia, you know that when you have the hyperactivations, then your heart might be undergo arrhythmia condition means that the rate of heartbeat is different. Okay. Then what is the ectopic beat? Ectopic is not actually is referred to not smooth of uh, uh, depolarization. There's some blockage happen during the depolarization process, which is may interrupt the contraction effect. So this condition we call it an ectopic beat. So for digoxin, of course they have because it's an old drug, so we a lot of information is available. So there's a drug interactions occur, especially with antacid, laxatin, and others drugs. This because the drugs mainly are add on your GIT tract. So That's why may decrease the absorption of digoxin. This cholestyramine is used to treat cholesterol, isn't it? Kaolin pectin also used to treat cholesterol, isn't it? So what will happen? They will prevent the absorptions of your cholesterol, digoxin. So, okay, until now tak ada masalah kan? So if you use together with calcium channel berkuasa sesperapamnya dia apa diazim. So it will decrease the heart rate because these two drugs will decrease the heart rate. You use them together, they will overcome. They will mask. We cannot say overcome. They will mask the activity of your digoxin. So there's another types of drugs that have been introduced to for chronic heart failure is dopamine and dobutamine. And this will stimulate your beta 1 receptor and then cause the contractions. Besides that, there's another type of drug we call arinomine, melanomine. They will increase the calcium contraction in your heart. So will cause the contractibility of your heart muscle. Okay. So okay, so we finished the the second topic. Then I will go back to another topic. I tried. So okay. So as last week, I do promise to share. Okay, to share some informations about the vasodilation study, isn't it? Okay, so okay. These are the setting for vasodilatory or vascular tone. So normally we have a tools we call power lab. The power lab will connect to connect with a transducer. Okay, and we have organ bath. So once you isolate your aorta or mesenteric artery, doesn't matter, depend on what type of artery you want to study. So you can hand according to this setup. Okay, so you have organ bath, you have transducer, then you have pelviser here. So if let's say you pipette in the vasoconstrictor, then your blood vessel will going to contract, isn't it? Once the blood vessel contract, they will drag the transducer. Transducer will send a signal, and then your computer will get the reading. So if let's say you put some uh, compound which is can cause vasodilations, so what will happen? Your blood vessel will going to dilate, isn't it? So once we're going to dilate, then there's no dragging, isn't it? So the reading will be taken by your computer as well. So you can compare uh, whatever you want. For example, you want to study nitric oxide, it's quite simple. You put the uh, name, incubate with name, then you pipette your study subject, study material, like extract or whatever you want to study. Then you compare the activity with name and without name. So you're able to differentiate whether they undergo this pathway or not. If let's say the difference is significant with name and without name, then you can consider they follow this alanine pathway. Okay. So another experiment, what we do is aircraft. These are the aircraft machines. So we put the sensor in the tail, on the tail. So the pressure of the animal will be taken. Okay. So you oral feed the animal with your treatment. Then for certain period, for example, 2 weeks, 3 weeks, 4 weeks, whatever. Normally the effect will be obvious after 3 weeks. So then you can compare the blood pressures. Okay. Okay, clear? Okay. Just now I mentioned this is a vascular tone. I go vascular tone. Okay. These are the vascular tone. So basically, when you look at the vascular tone, a lot of receptors are contribute. So calcium channel, here we have three types of calcium channel. The yellow color is indicate calcium channel. SOCC, VOCC, IPR3 also considered as calcium channel. Okay, this SOCC will related to circa, but so far it's difficult to study SOCC and circa because the involvement is quite it's not a direct involvement, so it's very difficult. Normally, what we can do is we can study VOCC and IPR3, okay, for calcium channel. So for potassium channel, we have four potassium channel: Kv, KIR, KCA, KATP. Yeah. So all of them can be studied because they are specific blocker, and then potassium channel is quite straightforward because the involvement is quite straightforward. So you can also study the soluble guanine cyclic. You can also study cyclic GMP as well. Okay, beta blocker. Okay, and also you can study alanine, uh, process cycling, process cycling here, and then muscarinic receptor. Okay, and what else? Beta receptor as well. So these are the vascular tone. So how we plan the experiment is before we start the experiment, we need to understand uh, the cascade or the pathway first. So once you understand, that's why it's easy for you to plan. Depend on what type of receptor you planning to study. For example, I plan to study calcium, potassium channel. Then I go and buy the and broker, then challenge with your drugs, then you're able to come out with a solid conclusions. Okay, this is another drawing for potassium for this vasculatum. So I stop here. So any question you want to ask?
Okay, students, there are any questions? I don't want to ask about the angina or for the chronic heart failure drugs. That vascular tone is invented by you, is it, Dr. Yam?
Pardon?
The vascular tone. Just now you
Ah,
show the mechanism. The
ah.
vascular tone is invented by you.
No, inventor might be. I go and read a lot of publications and then I summarize and then I draw this schematic diagram. We call it schematic diagram if I'm not mistaken. So this schematic diagram is drawn by me and we have published in a journal. Okay.
Mhm.
So
Yeah, good.
actually, we are not the first one because we need to read a lot, more than few hundred articles, and then we summarize all the finding, and then we come up with this vascular tone. Before we start the vascular tone research in many years ago,
Mhm.
because
So it's
in
just
our approach is quite straightforward. If let's say you want to do diabetic research, so what we ask the student, we want the student to do is first they need to write a review article on diabetes. So while they prepare the review article, they need to read a lot, isn't it? From there, actually they learn a lot. So after that, they only plan for the experiment.
yeah,
So,
it's very
so
complex.
they have the big pictures, whole pictures. So that's why they can measure all the the information.
Yeah, with that drawing, the schematic drawing, we can choose which part of the mechanism that we want to study. It's
You can
very
hope you can
comprehensive.
have whole pictures. Huh?
Yeah.
So I also draw the pain sensations, pain, sakit pain. You can
Mm.
refer the pain sensation. I also read many before I start another experiment. We also follow the same way. We go and do
For
researcher review
the analgesic or the
and then
antinociceptive?
ana-
Analgesic.
ana- analgesic, anesthetic, and analgesic.
Analgesic.
Mm.
Yeah. So for those who want to study about the hypertension or analgesic, can go to Dr. Young later for the master or PhD. Okay. Anyone, students from the students want to ask about this angina or heart failure disease? I thought there is one other slide, anti-arrhythmia, is it, Dr. Yap, that you sent to
Yes,
me?
yes. Anti-arrhythmia, I got no time to share. You can anti-arrhythmia.
Okay. Yeah, share it to the student as well.
Uh,
Okay, anyone to ask? Amanda, Vidya, do you understand about just now Dr. Yam explanations about the angina drug and all the mechanism? It's very interesting to learn this pharmacology. I also learned from you just today and last week because it's very related with the hypertension and this heart failure. You can use the antihypertension for the heart failure disease.
yeah. That's why the mechanism is repeating. The drugs is repeating.
Yeah, the drug is repeating. And that the compensatory response also, that's we need to consider when we use these drugs, right?
Yeah, compensations.
Okay, from the students, any questions to Dr. Young? Because today is the last day for Dr. Young to share with us. I want to ask or already understand. Already clear, it's very clear. Okay, if all the students already understand, maybe we can take another picture for today's session, Dr. Young. And
Yes.
all the students, please start your camera and, and please help Haikal or UD to take the screenshot. Now we can see all the picture, all the face of the students. Just now they close it. Okay, hi Carl. Please take the lead. I also have some problem with my camera. Okay, hi Carl, finish. Okay, thank you, hi Carl. Okay, Dr. Yam, thank you very much
Yeah.
for the sharing, for your knowledge, and for the slide also. And I hope that we can have another lectures for another topics and also another collaborations for both university.
Okay. Thank you very much.
Okay.
All the best. Huh?
Thank you for the best also for the TMs and also for the Ang.
Yeah. Yeah. Okay.
Okay. We will see
Okay.
you
See you. See you.
later
Keep
on
in touch. Keep in touch.
next
Anything
event.
please contact me if you need my help.
Okay. Okay, Dr. Yap. Thank you very much.
Bye
Okay,
bye. Bye
student
bye.
also.
Thank you, Leah. Thank you,
Thank
Leah.
you.
Bye
Thank you,
bye.
Dr. Thank you for all the
Okay.
students also and for the Amina also today has joined us today.
Okay. Okay. Bye bye.
All right. See you again. Okay, I will close the class. Thank you. Assalamualaikum warahmatullahi wabarakatuh. Good morning, all.